And can you hear me?
Perfect.
And
Take
can
it
you see my
away.
slides okay?
Yes.
Outstanding. All right. Well, thank you so much for the opportunity to speak today. I'm so sorry I'm not able to be there in person with all of you, but I have, been here virtually all day, listening, learning, and so grateful for this opportunity, and also so grateful for Dr. Ganshow for really, helping to set the stage for what I will be talking about today in terms of mainstreaming models as applied to patients with cancer. I have no conflicts of interest to disclose. And, I think all of us in the room, physical or virtual, are aware of, what we would think of as a traditional model of genetic testing and counseling for hereditary cancer risk, right? Where, most traditionally we're thinking about an in-depth pre-test genetic counseling session that is really helping to determine the eligibility of the patient for genetic testing, for example, with a family history assessment, providing education, facilitating that informed decision making about whether to undergo testing or not. Most traditionally, this would be done in person, but in recent years, and especially with the occurrence of COVID, that has really moved over to being more frequently delivered by telephone or video. But once a patient decides that they do want to have genetic testing for hereditary cancer risk, they would, provide a biospecimen, most traditionally blood, but increasingly saliva can be an option, and then would return for another in-depth post-test genetic counseling session, where the genetic counselor, the genetic professional is able to convey those test results, provide the appropriate risk management recommendations for the patient, and really help to facilitate their psychosocial adaptation to the information, as well as think about the broader familial implications and the potential for family communication. And this is the gold standard model that is what we think of as the ideal. But there are certainly situations and populations where perhaps this model is not the best or only way for us to move forward. And one population where this has really been gaining traction is patients who are already diagnosed with cancer. And this is because increasingly genetic risk information, germline genetic test results are so important for treatment guidance and treatment decisions. So, for example, for women with breast cancer, understanding if they carry a pathogenic variant in a hereditary cancer risk gene can have implications for what kind and what type or level of surgical intervention they want to use for treating their breast cancer. And now there are medications that are, recommended for individuals with specific germline variants. So, for example, PARP inhibitors work better in patients who have germline variants in BRCA1 and BRCA2. There are also a number of clinical trials taking place that are aiming at testing and evaluating targeted therapeutics that are targeted based on germline variants and DNA repair genes. So, consequently, there are changing recommendations even for which cancer patients should be offered germline testing. Because of the relevance of PARP inhibitors, genetic testing is recommended as part of standard of care for certain patients with breast cancer, ovarian cancer, prostate cancer, pancreatic cancer. And so, consequently, getting this germline genetic testing completed has a really critical timing element. So, there's a need for efficient testing to happen so that patients and their oncology team can have these test results and bring that into their decision making about treating the disease. This also can raise a bit of a consideration about, well, who are the population of patients undergoing this testing? Increasingly or to date, germline testing for patients with cancer has focused quite a bit on the advanced cancer stage, patients who have a poorer prognosis, and especially if you're also thinking about eligibility for clinical trials with treatment implications, you can be, again, thinking a bit more about patients with advanced or late stage disease. And so that is not always the case, but when that is the case, you also start thinking about what is the relevance of the information for their individual future cancer prevention versus what might be the relevance for at-risk family members, and thinking about how to ensure that information also gets to those individuals. And so really there's a very different decision context faced by patients with cancer who have this opportunity for germline genetic testing. And arguably, we could say that this is perhaps a very different setting than the primary care population that Dr. Ganschow was just describing. Here, you could argue it isn't necessarily as much of a preference sensitive decision about whether to have germline genetic testing when it is a patient with a cancer diagnosis who they and their oncologists need this information to guide the management of their current disease. And then in addition, there is a limited genetic counseling workforce. And so thinking about ways and models that the genetic counseling workforce that we have can be best deployed, can really practice at the top of their game, has really led overall to these idea of these mainstreaming or point of care models. And the way I like to think about these, is that they're models where we're sort of swapping out our pre-test counseling with something else. And in the setting of patients with cancer, it can often be thinking about identification of patients and the delivery of standardized education by non-genetics providers, like the oncology care team. Still having that biospecimen collection, and then bringing in genetic counseling at the back end to provide that in-depth post-test genetic counseling support for the delivery of results and management recommendations. Although it is also important to note that there's a lot of variability in how these models are deployed in terms of which patients potentially get that post-test genetic counseling. So it can be dependent on what results a patient gets. Oftentimes, most models are definitely going to be having post-test genetic counseling for patients with a pathogenic variant identified, but there will definitely be variability across, what's published and what's being used in practice as to whether counseling is also given to patients with variants of uncertain significance or to patients who get negative results from this testing. But all of that being said, the literature that is starting to accumulate specifically in the setting of using mainstreaming models for patients with existing cancer diagnoses has started to, really demonstrate high levels of patient acceptability of these models of care. So most of the work that has been published to date has looked at specifically mainstreaming that is delivering BRCA1 and BRCA2 germline genetic testing to women diagnosed with breast or ovarian cancer. And so most of these studies have been qualitative and observational in nature, and they have found positive outcomes in terms of, high levels of uptake, patient satisfaction, and minimal distress. There's one RCT that has been published to date from Australia that looked at a mainstreaming model that employed written educational materials and in-person post-test counseling versus a control condition of in-person pre- and post-test genetic counseling that found that the two models delivered, similar levels of decisional conflict amongst patients, similar levels of distress, similar levels of knowledge. But we know certainly that genetic testing doesn't typically involve just a single gene or, a single set of genes anymore, that there's been such an increase in panel testing as the way that germline hereditary cancer risk is evaluated. And so there's starting to be literature looking at mainstreaming that employs multi-gene panel testing. Most of it is still in breast and ovarian cancer, and somewhat less often, we're starting to see studies in prostate and pancreatic cancer as well. And these studies have all been observational, cohort, or retrospective in nature, but they are also suggesting that there's high levels of satisfaction among patients and similar levels of decisional conflict, distress, and knowledge as the more traditional models of care for delivering genetic services to patients with cancer. And so our team has also done some work in this space that I'll be talking a bit about today. So this was my institution's experience with really trying to understand patient responses over time to a mainstreaming model that was used to deliver multi-gene panel testing to patients with cancer. And so we conducted a single-arm prospective study across two sites. So across my home institution, Memorial Sloan Kettering Cancer Center, as well with our collaborators at the University of Pennsylvania. Our study participants were all adults who were predominantly advanced cancer patients, and they were diagnosed with either ovarian, prostate, or pancreatic cancer. They needed to be deemed clinically appropriate for multi-gene panel testing by their oncologist, and they also needed to be English fluent to participate in the study. And this is an overview of our mainstreaming model and our study design. So it began by offering patients pre-test education that consisted of a brochure and a video. This was offered in the oncology clinic in conjunction by the oncologist with support from our research team. The materials, this pre-test education that we had created, we had a 2-page or 6-panel brochure on what is multi-gene panel testing, as well as an 8-minute narrated animated video. And together, these two elements provided information on hereditary cancer syndromes and what is multi-gene panel testing and what are the risks and benefits of the testing. After patients reviewed those materials, they were offered the ability to consent to the research study and to undergoing multi-gene panel testing. If they agreed, they provided a blood sample, and then they completed a baseline survey assessment. When the test results were available from the testing lab, they were sent to the study genetic counselors, who would then call the patient by telephone in order to provide post-test genetic counseling, return the results, as well as do a family history assessment at that time. Patients then completed a second assessment within 3 weeks of getting their results and having that genetic counseling session. And then they completed a third assessment 3 months later. And they had the option, if they wanted to, of opting into an in-person visit with a genetic counselor as like a secondary appointment if they were so inclined. So overall, with this study, and similar with what has been reported in some of the other literature, we found a high degree of acceptability in terms of multi-gene panel testing uptake. So 90% of the patients who were invited consented to the study and to having multi-gene panel testing. But we did see some differences in who took part in this. So decliners were more likely to be Black or African American. We had a 27% refusal rate among Black or African American patients compared with a 7% refusal rate among white patients. Decliners were also more common at the University of Pennsylvania than at MSK, but we saw no differences in uptake based on sex, ethnicity, cancer type, or age. Overall, we had 1,054 patients who underwent multi-gene panel testing. Ultimately, 10% of those individuals were found to have a pathogenic variant in a hereditary cancer predisposition gene, and 16% were found to have a variant of uncertain significance. The remainder had no variants identified. In terms of who completed our surveys, we had 803 people who completed at least that baseline survey, across a wide range of ages. We were frankly pretty delighted that we had a majority of males taking part. So 68% of our respondents were male. So, a real difference from what has been previously reported, where much of the work has been done in the setting of breast and ovarian cancer. But our sample was predominantly white, 84%, and majority non-Hispanic. And also very highly educated sample, 64% had a college graduate or greater level of education. All of our ovarian cancer patients came from MSK. Almost all of our pancreatic cancer patients came from Penn, and then we had a nearly equal split in terms of institutions from where our prostate cancer patients came from. And so we looked at a number of markers in our surveys around overall acceptability as well. And so at baseline, the time point after having undergone that standardized pretest education by the oncologist and study team, we found overall that our sample reported high levels of satisfaction with their pretest education, high levels of decision satisfaction about the decision to have a genetic test, and low levels of distress in terms of generalized anxiety and generalized depression. But we did see, not such great news in terms of knowledge. So we assessed knowledge with a true, false, don't know scale of items that were really based on asking, questions and knowledge that was included in the pretest education. Overall, on average, only 56% of items were answered correctly by the study participants. Somewhat reassuringly, most of the not correct items were don't know. So, it really seemed that people didn't know the things versus having, misinformation or misperceptions about the answers, but still, not what we would ideally like to see. As I mentioned, because we had multiple time points, we did also look at outcomes over time, and I could always talk more about the things we saw, but I really want to focus specifically on this knowledge measure, because what we found was that for all participants, regardless of the type of results they ultimately received, that yes, knowledge was, suboptimal at baseline after experiencing the initial pretest educational materials. But following the genetic testing session, genetic knowledge increased significantly for all participants, whether they had a pathogenic variant, a VUS, or no variant identified, and remained elevated up to 3 months later. I think this is so important because it really emphasizes, that genetic counseling is very critical. And, that with these mainstreaming models, it's really important, I think, to make sure that genetic counselors, do retain a role, and thinking about where to deploy them is what's, I think, paramount here. And so again, and just a reminder, for our study, everybody got that post-test genetic counseling, regardless of the results that they received. So, we thought about this as, really, some nice evidence that this model of care, can be acceptable to patients at our center, to patients diagnosed with a variety of different cancers. But this work, certainly had some really notable limitations as well. Obviously, there's some room for improvement in our materials because knowledge was not where we may want it to be. But our sample was also limited, right? It was all English speakers, predominantly white, non-Hispanic, and very well-educated population. And, we certainly know that existing models of genetic service delivery, as well as much of the work that's been done with mainstreaming models in the cancer treatment and, cancer affected space, really have done little to improve health disparities among racial and ethnic minority, as well as medically underserved patient groups. So Black, Latina, and non-English speaking patients have, as we've heard today, they have lower awareness and use of genetic services. They have greater unmet needs for discussing genetic testing with their providers. They face, specific barriers to accessing genetic services, including cost, language, medical mistrust. They also have a greater likelihood of having a variant of uncertain significance detected, since many of the databases and data sources that are used to understand human genomic variation are based on predominantly European ancestral groups. And there's also some evidence of lower dissemination of genomic information to family members among these populations. So there's a lot of work to be done in the space of trying to address some of the inequities that exist. There are also some important considerations when we think about patients for whom English is not their preferred language. So patients with limited English proficiency are more likely to also have limited health literacy, and these factors together both contribute to communication challenges and medical encounters. Challenges can also exist when you're integrating medical interpreters into care. There can be issues around inaccurate translation or unfamiliarity with genetic jargon or concepts among medical interpreters, lack of trust among the parties involved in the communication exchange, the patient, the provider, the interpreter. And certainly there are concerns about the level of engagement, the quality and extent of dialogue and question asking that take place when a third-party interpreter is brought into that. There's also a limited availability of high quality supplemental educational materials that can be used in the genetic space, materials that are available in non-English languages. So a recent review looked at 246 resources that had been identified that were available in non-English languages related to supplemental genetics education or genetic support materials. Most are available in Spanish, French, or Russian. Only 9 were specific to cancer. So, there's some real gaps in the kinds of additional resources that exist. And so addressing some of these issues is part of the work that my team is now currently pursuing. So, as part of a study we call Imagine, Improving Access to Genetic Information for Everyone. This is a UO1 funded study from the National Cancer Institute. And what we're really trying to do is extend that pilot work we did with a mainstreaming model for our, MSK, University of Pennsylvania populations, and try to, expand this from more of a, genomic medicine and inequity perspective. So we are specifically trying to develop and then test and evaluate what we call a linguistically and culturally appropriate mainstreaming model, specifically for the delivery of hereditary cancer multi-gene panel testing to patients who are affected with cancer who are diverse in terms of their race, ethnicity, their language, and their education. And so we are partnering with 4 community hospitals in New York City. Our hospitals are Kings County Hospital Center in Brooklyn, New York, Queens Cancer Center in Queens, New York, Jamaica Hospital Medical Center, also in Queens, New York, and then the MSK Ralph Lauren Center, which is located in Harlem, New York. These settings all treat a higher proportion of Black and Latina patients. They treat a number of non-English speaking patients. Specifically, we are focusing on patients who speak Spanish or Haitian Creole as well as English. And the communities that are served by these hospitals also have a higher level of lower educational attainment than, as I said, our original population. So, ranging from 21 to 52% who have a high school or lower level of education. And so our overall study consists of what we think of as 2 phases. So our first phase has really been focused on this development of our mainstreaming model of care. And so, phase 1, we are focused on material development and refinement. And so what we did was we used formative research methods that were guided by the learner verification and revision approach in order to adapt those existing mainstreaming model materials that we used in our pilot. So our pre-test educational brochure, our post-test educational video, but we also wanted to think about the post-test genetic counseling encounter, and were there aspects of that experience and encounter that we could also be attempting to improve upon. And so specifically, we are focusing on what we call our post-test clinic visit summary. So this is a written document that summarizes the patient's test results, the medical recommendations for what they should be doing to manage their cancer risk, and the kind of information to know about the testing. That this is something that's given to all patients as part of our standard of care. So taking our standard of care document and thinking, can we refine this in some way to make it maybe a better fit for this population and for this setting? As well as a family letter. So when a patient has a positive result, a pathogenic variant is identified, our counselors will traditionally give the patient a written letter that they could use to share with their family members in order to convey that risk to those family members and encourage them to get their own genetic testing, promote cascade testing. So we took these 4 materials and have gone through a process to try to refine and improve upon them. So we began with an expert review phase where our study team, as well as our external advisory board, which consists of content experts as well as patient representatives, reviewed all of these materials and the English language versions of all of these materials and made suggestions, revisions, and modifications to really try and make them, more linguistically appropriate, less complicated, and to, really try to hopefully meet the needs of the community hospital populations where we would ultimately be deploying this model of care. Once we had our refined version of all the materials, we then went through a process of translation and transcreation. So this is where we had professional translators translate the English versions into Spanish and Haitian Creole. But then the transcreation process involved having native speakers who are part of our study team, as well as who, are medical experts, both of those groups represented, review the translations in order to ensure that our intended meaning and the content is retained in the translation process. We then took those materials, the refined English and translated versions, and did a series of cognitive interviews with patients who were recruited from the community hospital sites in order to get their feedback and evaluation on the content and quality of the materials. And then lastly, our study team took feedback from those interviews in order to do a final revision to attempt and address the concerns and questions that patients raised. And, some lessons or findings from this process. One was that, our transcreation we found, we think was really critical in helping to ensure that the intended meaning was retained in our materials. Our native speakers identified these situations where the direct translation into Spanish or Haitian Creole just really didn't convey what we wanted it to, and introduced some unintended meanings. So I have, just as one example here, one of the terms, that we really spend a lot of time thinking about how to best describe is, pathogenic variants. That's what the medical community, genetics community would say is the right term to use to describe a, positive result or a mutation. But we've thought about what other terminology, what might be most appropriate, and we've kind of landed on harmful changes as thinking about that might be a simplistic and approachable term that we would want to use. When we sent our materials off to our professional translators for Haitian Creole, they replaced the term harmful with the Haitian Creole word nuisible, which is technically accurate. But when our native speakers, reviewed the translation, they identified that actually this term really is more like annoying versus harmful, and that's certainly not the kind of genetic change we were trying to communicate. And so our native speakers were able to identify damajan as a, alternative word that might be getting at more of the damaging aspect of harm that we were trying to convey. Ultimately, with our cognitive interviews, we even further refined it and landed on danger, which is more of like dangerous change, as being a term that really resonated with the community and felt like, was something that can, kind of aligned with our English translation, but also, conveyed what we wanted to. Our cognitive interviews, really helped to demonstrate the acceptability of the refined materials, but also found some areas for improvement. So we conducted cognitive interviews with 61 patients recruited from several of the community hospital sites, representation of in terms of race and ethnicity consistent with the communities treated by the hospitals. We had a number of individuals of lower educational attainment. So 67% of our cognitive interview participants had less than or equal to a high school education. And we included individuals who spoke Spanish, Haitian Creole, and English. For example, with these interviews, we were able to land on and get confirmation that harmful change was a term that was, most preferred across our interviewees, across languages. It was preferred over mutation or variant. We, as part of our interviews, asked participants what they did was they, looked at each of the materials in depth over a 90-minute, interview, and found that across the participants that, the vast majority thought that the materials were relevant to people like them. They found them informative. They found them helpful. Very few found them difficult to read or unclear. About 40% did feel that they required a lot of mental effort, although, that doesn't seem to maybe be at the, kind of sacrificing the informativeness or the helpfulness of the materials. But as I said, they did identify areas for refinement. So for example, some of the things that really emerged were that we, especially given that these were patients who have cancer, that is our target population with this work, we really needed to emphasize that genetic testing does not find cancer early. This was a misconception that we, really needed to give some additional space in our materials to addressing. We needed to give context for gene nomenclature, right? What are these letters and numbers, and do you need to know what they mean? We needed to give some foundation as to how cancer happens. really being repetitive and reiterating the possible result types a patient could get through testing, and really working especially on our clinic visit summary document to try to simplify the presentation of their own results were things that we took away and folded into our final revision. Our formative process we found was really helpful in systematically improving the readability of all of our materials. So, I've mapped out here in this table the original materials. So, what was used in our original pilot in terms of our brochure and our storyboard, what is used in traditional clinic practice in terms of our clinic visit summary and family letter. That's our original. What was the interview version? That's the version that was refined based on our expert feedback and our external advisory board. And then the final version is where did we get after bringing in the feedback from the cognitive interviews. And what we were able to do is we were able to really improve the readability of our materials from an average of a 10.4 grade reading level down to an average of a 7.3 grade reading level. I'm really happy with this. It's could always be better. NIH recommends that health materials be at a 6th to 7th grade reading level. Although I think anyone who's ever, kind of worked in this space knows that 3-syllable words or words longer than 7 letters, like bump up your score. And so it's really hard when you're talking about genetic testing, to not run into these challenges. The systematic process we think really did help get our materials in a more accessible space. And so, what we landed on, we now have a much nicer, I think, 6-panel brochure that comes in English at a 6.8 grade reading level. We have a shorter, 6.5-minute video that comes in at a 6.9 grade reading level. And again, we have, translations of all of these materials plus our clinic visit summary and letter, for a number of different cancer diagnoses. And so we are now in phase 2 of this work where we are conducting an RCT across our 4 hospital sites. Ultimately, we're still opening up each of those sites, waiting for, the IRB multi-center kind of thing to work its way through the system. But we will be recruiting our English, Haitian Creole, and Spanish-speaking patients who are diagnosed with breast, ovarian, colorectal, prostate, and pancreatic cancer, and randomizing them to either our linguistically and culturally appropriate mainstreaming model or a standard of care where patients would have in-depth telegenetics pre and post-test genetic counseling, a number of assessment time points to really try and understand whether this model of care will be better in terms of overall satisfaction with the decision, uptake of testing, and other psychosocial and behavioral outcomes in our population. And so overall, our goal here is really to try to promote effective risk communication, decision making, and more equitable delivery of genomic medicine to patients with cancer diagnoses, and hopefully lead to better public health and familial benefits as well by down the line leading to some cascading as well. So I just want to acknowledge all the contributors who played such a huge role in this work. It takes a village in our funding as well for this. And I will stop there and would be glad to answer any questions that folks may have.
Thank you, Dr. Hamilton. We're going to open it up for questions. If you can just say your name for Dr. Hamilton and push your button.
Hi, Jada. It's Caitlin.
Hi, Caitlin.
Thank you for your presentation. I was curious about some of the cascade testing opportunities you sort of hinted on throughout your presentation. And I know it wasn't the focus of your talk, but just as you're thinking about next steps and really thinking about population level work, right? What are some areas that you see heading for cascade screening?
Yeah. I think it's so critically important. And, and I would say, my colleague and collaborator, Ken Offit, led a paper that I co-authored a couple of years ago in JCO, where we were also really just mathematically kind of calculating out, what it would take to identify all of the individuals at risk of hereditary cancer syndromes. And, one of the most efficient ways to do that is to start with testing cancer patients, right? They have a higher prior probability of having a pathogenic variant. And if we could, test at that level and then effectively cascade out, if we could get 70% of the family members, first, second, and third degree relatives tested, we could identify all the mutation carriers in the US in a decade. But we've got a long way to go until we get there, right? Because right now, it's about 30% of patients' family members are undergoing cascade testing. So, it's a secondary aim of what we'll be looking at is the amount of cascade testing that does happen in this particular study. I think that that's a place in mainstreaming models in general that is really ripe for research. Very few studies have been looking at what is the cascading that happens following a mainstreaming model of care. So I think it's really critical that we think about, what are ways that we could better intervene in that population. A separate study that we have ongoing right now is a study where we are attempting to really, improve cascading by leveraging digital tools and provider outreach. So really focusing on a model of care like that has been demonstrated in, more of the hypercholesterolemia, familial hypercholesterolemia literature around having providers outreach to at-risk family members in order to try and encourage them and facilitate testing. So, we're doing that in a separate study where we're testing that against standard of care. But I think in a perfect world, it might be nice to see if there could be a way to, further funnel some of these patients into that model where not only can we, help them get efficient access to their genetic testing through a mainstreaming model of care, but then also use, techniques like provider outreach to try and encourage the dissemination and cascading of testing in these families.
I have one question.
Yeah.
We've talked a lot today about sort of engaging communities, and one of the things that's come up is sort of scale. So I wondered if you guys had thought about sort of how do you scale this across populations, across languages? We had earlier talks about AI. I don't know what opportunities and, if technology has been a part of the solution, but can you just walk us through some of the things that you guys have been contemplating?
Yeah. I mean, I do think, certainly thinking about, multiple languages, additional languages would be, important and wonderful, next steps if we are, able to see that this model, it is effective in the populations that we're currently deploying it in. I think that, we're actually not attempting to do any particular innovation in terms of the interpreter space. I mean, we will be using the interpreter services of the hospitals, and so will therefore still be, subject to some of the challenges and limitations that exist there. But I think that is a space where there are others doing some really interesting work that I think, we could be, and others can think about. Galen Joseph in California, has been working on training programs for medical interpreters to help them better understand genetic risk information and be better employed in doing that. Some of my colleagues at Memorial Sloan Kettering are thinking about, and testing ways of using remote simultaneous medical interpreting, like the UN style interpreting in, other care delivery contexts. So I think there are places like that too. It's not AI, but and actually, to be fair, I think that there are times and places where AI does can be woven into some of that medical interpreting. It's not my space, so take that with a giant grain of salt. But, but I think that is another domain where, as we think about trying to extend our genetic counseling workforce, help patients get access to care, and minimize systemic barriers to care, that this can be so helpful. And I will say, even just, I think what we're trying to do with making our clinic visit summaries available in other languages, like that's not something we even do in standard practice today. Like it's available in English on the portal, and that's that, but I mean, what a, maybe simplistic and huge innovation that could be so helpful to so many patients. And I think, again, as AI models get better at even doing translations, like that could be another way, not just redesigning the layout and the content, but then thinking about how AI could be used to make these written materials just more widely available to patients of various linguistic backgrounds.
Thank you for that. Are there any other questions? Another round of applause?
Thank you.